Thank you, Dr. Bolan. Good morning. So just a few months ago, the United Nations startled the world by sharing this chilling statement: the most dangerous place around the world for women is. Any guesses? Yes, I heard that. It's home, home sweet home. Because in 2017, 58% of women homicides were committed by their partners or family members. And what's more horrifying is that these killings were not usually spontaneous incidents, but part of a long-standing escalating abuse. So that means the society and healthcare providers like us witnessed these episodes, but couldn't do anything about it. So I'm an emergency radiologist, and this is my everyday work. I get one-line history for interpreting X-ray, CT, or MR. Here is the history: 38-year-old woman strangulated and hit by her husband. And we see this radiograph. It's a broken arm bone. As I'm reporting this radiograph, I see another radiograph just popped up on my screen. And this radiograph is from 2005. This is again broken arm bone, but it's of the other side. And this was 13 years ago when she was 25. So in between the ages of 38 and 25, she had almost 68 radiological studies with us. So she gave us 68 opportunities, and we reported these X-rays. How much time can you afford between the ages of 25 and 38 to come to these appointments, not to mention the countless healthcare visits she had at the Brigham Health? So we did diagnose this fracture. We reported the fracture, but we missed the real diagnosis. Her actual diagnosis remained invisible for a very long time. She was going through the intimate partner violence, IPV, which is defined as physical, sexual, or emotional violence between current or former partners. Physical assault is still the most common type. 1 in 4 women and 1 in 9 men have reported experiencing severe form of physical violence in their lifetime. Annual healthcare costs are higher for victims because there are physical and mental adverse effects. Even for the children, so-called silent victims have higher healthcare visits. Of course, it comes with a huge price tag. And more importantly, more than 55% of female homicides are linked to IPV. The good part is IPV is preventable. It just needs to be diagnosed early to offer early intervention. And there are studies showing the beneficial effects of early intervention. The biggest obstacle in early diagnosis is underreporting by the victim. We often see most severe cases of violence or homicides, while the vast majority are submerged, the iceberg phenomenon of IPV. Now, of course, we all understand barriers for victims. The victim is often struggling with feelings of fear, embarrassment, and love. And if you are thinking that it would not happen to someone who is financially independent or well-educated, let me share these statements with you. So here is a Brigham employee. I'm good at hiding my bruises because for 16 years, I have walked down the Brigham Pike and no one knew. Here is an MGH physician. I was in a physically abusive relationship with my physician husband for almost 10 years. And then came this absolutely heartbreaking news. An ER physician coming to save lives was brutally killed by her ex-fiancé in a parking lot. So no one is immune to IPV. Now, victims present to healthcare providers before they present to criminal justice or social service. This is the reason we screen for IPV. But screening is not working. We have very low identifiable rates, and we keep missing these opportunities. Because CDC has reported barriers for providers too. The providers may be uncomfortable asking this particular topic. They don't want to offend the patient or the spouse. There are time constraints and, of course, misconceptions regarding patients' exposure to IPV. And as a radiologist, I have been reporting these injuries. Our technology has advanced, and now I can see these injuries better. For example, in this patient, there are multiple different fractures as she was hit with a hammer. And it's interesting that we never make an active effort in reporting these injuries or making the diagnosis of IPV. But now it's all changing. Our pilot study just got published actually this month in Radiology, and it's the first attempt to transform the role of radiology in IPV. By recognizing high imaging utilization, location and imaging patterns specific to IPV, injuries inconsistent to the history, and old injuries of different body parts, the radiologist can generate an objective, unbiased report. Now, until 2017, this particular fracture was reported as just fracture of distal ulna. But now, our radiologists are going to raise the concern of intimate partner violence, especially if there is history of fall, because this particular fracture doesn't happen because of fall. It often happens when you are raising your forearm to protect your face if somebody is hitting you, just like that. And if you are falling or falling on outstretched hand, it's the radius, the other thicker bone, which gets injured. So we have defined predictors, imaging predictors, and clinical predictors in our pilot study. For example, nasal injuries, so the nose bone injuries and facial injuries are more common in these victims. But even though we understand all these predictors, we really don't have time to access and review in every patient. There are silos of subspecialized radiology. So a neuroradiologist looking at the nose bone fracture might not look at the orthopedic x-rays or musculoskeletal radiographs to see the imaging pattern or injury specific to IPV. Let's say even if we have unlimited time and resources, there's so much we can assimilate. And of course, we all focus on acute situations. So often these patients come to the ER with acute injuries, and we are just focusing only on diagnosing acute conditions rather than focusing on long-term comprehensive care. So the only solution is to have automated identification of IPV. So we are using NLP to extract radiology and clinical predictors to generate a clinical decision support. This clinical decision support rule will then be validated on a testing set of IPV and control cohort to ultimately generate a risk probability for IPV for every patient. Now remember, this risk probability is not just based on current visit. It would be based on longitudinal or historical imaging and clinical data. And ultimately, this will result in automated alert, which can then be integrated to radiology reports and EHR. So this is how our automated alert will look like. So we'll have, because we are including both control patients and IPV, proven IPV patients, we can be as specific as in this situation where we can give the numbers. So once the patient has moderate or high risk probability of IPV, then we can have in-depth screening instead of screening everybody, just focusing on those patients. And we are actually designing these conversational guides, which would be more based on the automated alert with our clinical collaborators to ultimately make the invisible visible. So this tool is not only going to impact significantly victim, family, community, and society, but it will also empower healthcare providers with powerful tools and robust objective data by which they would feel comfortable approaching the patients. And we are already talking with radiology reporting company so that we can integrate this tool in radiology reports. Of course, it comes with tremendous cost savings. So this is a tool to be implemented at every hospital and every clinic. And by reducing the ER volume, it would improve access to healthcare. So these are our collaborators, and thank you for your attention.